temporomandibular disorders and orthodontics. Temporomandibular disorders is a large scale of diagnosis that you could make, and it is presented often as a number of clinical problems that patients report back to you. And basically it's a musculoskeletal disorder, so it's either problems with the muscles or with the skeletal part that is temporomandibular joint. But also patients could report both of those, but also the third party, it's the associated structures. They can also report pain in ear or in eye, in forehead, and in the back, and all of this goes under the big umbrella of temporomandibular disorders. And it is the most prevalent clinical entity affecting masticatory system, so you will come across it, or you did already come across it. Maybe you experienced it, or none of you, just me. Okay. So, orthodontics and temporomandibular disorder became enemies sometime in the past, when a patient sued her orthodontist because, so she was at the age of 16 and had presented with class 2 subdivision 1, and her treatment option was camouflage with extraction of upper first premolars, and the biomechanics was to pull front teeth backwards, and also they used headgear as additional anchorage. And then after the treatment was over, she complained of the sounds in temporomandibular joint in terms of clicking, also pain, limited opening, and headache as well. And she felt that it was as a result of her orthodontic treatment. And then the judge was also convinced, after the two lawyers brought forward their reasons, that indeed over retrusion of the upper incisors was the cause of her pain. And it was then decided that the orthodontist had to pay a rather large fine, and so he went bankruptcy. And the thing is that there was not enough of scientific evidence either to prove or disapprove of this. Is it possible that after you get extraction of the first upper premolars, you actually develop TMD due to those kind of biomechanics of the retraction of the upper incisors? And then later on, so orthodontists became very much worried about their future business, because until that time, the prevalent thinking was that it was some dental-based problem that really causes your TMDs as a result of either you don't have a perfect occlusion or you have some teeth missing or something like this. But also at the same time, people noticed that even if you have perfect dentition and all of your teeth and you attend the best dentist that you could ever have, because it was then considered best dentist could fix your occlusion so well that you will be happy for the rest of your life. It was found out that even if the perfect doctor did everything right, patients still sometimes complained about pain in this area that we call TMD. So, and then it was International Consortium for the Problems of Pain in the Facial Area, what should I say, like developed, or group of people from, like they're also prosthodontists and orthodontists and all kinds of people that are involved in pain in this facial area. And nowadays it is called INFORM, so International Network for Orofacial Pain and Related Disorders methodology. And they're trying to do high quality research in this area in order to explain and try to understand what causes TMDs and what can help you to cure it. So after a very many years of research and quality research, like something that really could you say, yeah, it's a sound methodology, that really you could draw conclusions up against it, decided that nowadays we cannot think that it's something wrong in your occlusion or something rather perfect in your occlusion that will spare you from developing TMD, but rather it's a biopsychosocial thing, something that is influenced by various reasons in order to, so some people will develop it during the life, some will not, but it's a mixture of some social, psychological factors and also etiological factors that are dentally based. So you have a mix, a bit of everything, and then in some people it will be developed. And some will never report problems even if they don't have one sound teeth in their mouth, right? So, etiological considerations could be, but not in all people, because we know that psychology and social status and everything modify this response of a certain person to this particular cause, let's say, and not everyone who has some problem or some acute change in occlusal condition will report problems. Because every time you put, for example, bite turbos, like raise your bite or something, you put some kind of occlusal change, right? But not everyone comes back and reports TMD problems, right? Then also you could have orthopedic instability coupled with loading that also could develop TMD problem with some people, but not with all of them. Trauma, like if you get hit by a ball or by child's head, for example, in a chin, and then you have trauma in your joint, and that could cause you temporomandibular problem. Or if you had a series of microtrauma, so that means repeatedly punched a little bit with a ball or something. Someone who's training volleyball, for example, is often prone more to developing TMD problems. Also, emotional stress, like very important mediator to develop your TMDs. That puts your muscle under strain, and in that means causes you problems later on. Then deep pain input. Deep pain is a pain that comes from muscles and the joints. So it doesn't have to be just the pain in the temporomandibular joint. It could be also, for example, neck pain. If you had like a car accident and then got whiplash injury in your neck, then you have muscles from the neck that are sending autonomously impulses to your masticatory muscles and cause them to be in cramps. And then patient comes to you and reports pain in all of this area that is TMD problem, but the real cause of the problem is in your neck injury. So until you resolve your neck injury, you won't also be able to resolve problems in this facial area. And also parafunctional activities, if you have a number of them, and if you do it quite often, you could also report problems with TMD over time due to overload of the masticatory system, both muscles and skeletal components, but not everyone who chews gum will report back pain. So it's not that simple. And the most that you could do from your orthodontic side, you could try to improve orthopedic stability, but not in a sense that you will establish perfect occlusion, because there's no such thing, or position your condyle in a perfect position, because there's no such thing. And research has shown that you cannot predict where will you put the condyle during your orthodontic treatment, and that it is not reproducible at all, something that you imagined that you will do, that you actually do it. So the Roth philosophy that is based on this perfect condylar position is not actually accurate enough that you could say, yeah, really, I did this. And also, back in the 70s, it was considered that the perfect condylar position is the most backwards and upwards within your fossa, and then it was changed to most upper position, central and upper. And nowadays, most of the people, do you notice the difference? Not the perfect position, but most people have their condyles positioned in upwards and forward position. Yeah. So it changes as our diagnostic gets better, And as research gets better, so we get more knowledge about it, and then we are less certain into certain treatment options that were like offered as a cure for TMDs. TMD cannot be cured by a line in perfect occlusion, okay? Because people with perfect occlusion can also develop TMD. And then psychological considerations like anxiety, somatosensory amplification, hypervigilance, catastrophizing are all things that one of us has as a burden of his own development, or also some genetics in it and previous experiences. And that's something that modifies our perception of pain, our perception of problem within our occlusion or in teeth and everything. And it is very dangerous to do any kind of irreversible dental treatments in order to help them, because it's not a problem within dentition that will cure them. It's a problem within their head and some emotional status that they have to deal with in order to feel better and to resolve this fixation on particular tooth, you know. So one example, and it was also as a result, so I will show you now. So you could have a little bit of everything. A little bit of parafunction, a little bit of stress or a lot of stress, some kind of trauma, microtrauma, anything that could help you develop TMD. And if sometimes you will develop it and some people won't get it, or sometimes you will be burdened by your current status, or if you have a new feeling and there could be another day that you don't even notice any change and you're not bothered by it at all because you have some other things that are more important to you. So you could develop it, but not everyone. And also research was done in a sense, this is a term that explains this hypervigilance. So occlusal change was made intentionally on people that were participating in this research, and you had people with TMDs previously reported and some healthy subjects that never reported any problems within their TMG. And what was then? So different people react differently to some of the occlusal change that they had within their mouth. So it was always the same height of this foil that was put between the teeth. And in some people, they develop like tolerance to this new state, and they try to avoid this something that's bothering them. They don't go extra on this particular place, and they restore their normal function very easily. They don't report problems, they don't report pain. On the other hand, you have people that did have some kind of TMD problem earlier in the past, and they don't have any tolerance at all to this new change in their occlusion, and they immediately report some kind of TMD problems. So no reserve or something like to hold them back. So maybe it bothers me, maybe it doesn't, or it bothers me, that's it. You know. And then you have some people that try extra, so they didn't have any TMD problems before, but they were like bothered by this occlusal interference, and they tried to explore it a bit more. And then over time, they actually increased their parafunctional activities by trying to explore this new thing that's between the teeth and develop TMD symptoms. So what's the thing? It's something similar that you could do, excuse me, when you tell your patients, please be extra careful if this new bridge or new restoration bothers you, because they could actually develop this occlusal hypervigilance and make amplification of their somatosensory experience. So you don't have to tell them, because you could never make it the same as it was before. So don't make them hypervigilant. Yeah. And then, after the research was done, you have orthodontist and prosthetics specialist who refuted like any possible association between orthodontics and TMD based on quality design research. And then they explored particularly some kind of mechanics that were used before, for example, extraction of upper premolars, as part of orthodontic treatment, does not increase the risk. And what is important, signs and symptoms can occur in healthy persons. So that's the first thing. So secondly, signs and symptoms of TMD increase with age, particularly during adolescence, when people get more burdened with different kind of stuff. So you have this psychological component that is very important, extra stress that is often put on children in terms of their school performance or sometimes sport performance, whatever. And it's just a bad luck that at the same time, when TMD arises in general population, those very same population often goes into orthodontic treatment. So it is concurring and can happen at the same time. It can happen during your orthodontic treatment that patients start to report some kind of problems within their joints or muscles. And you cannot just say, oh, it's nothing. You have to explore what is it, what happened, but you have to reassure them that it's not because you do orthodontics, it's just it happens at the same time that you're doing orthodontics. And you cannot promise them that you will resolve them from their future TMD problems just by doing orthodontics for them. It would be a bad thing to promise. Then they also explored any particular mechanics. No particular mechanics orthodontic could provoke your TMD more often than any other mechanics. Ideal, znači specific, natologically ideal occlusion does not result in TMD signs and symptoms. And if you would have this from the prosthetic point of view, ideal occlusion with the curves of Wilson and Spee, and we know that orthodontists don't like this, we like it less. And if it would be like canine guided protection occlusion, then you would have to be actually in class 2 in order to be able to have this canine protected occlusion. And we don't want to do this, right? No method of TM disorder prevention has been demonstrated. So you couldn't promise anyone that whatever you do, you will prevent him from developing TMD. It's a multifactorial thing. It's modified by how a person feels and everything else. So you couldn't promise someone after you're done with me, you'll be sure for life. Make sure that you don't do that. I don't know, only this professor can promise this to his patients or not, I don't know.
Domingo Martin.
Domingo Martin. And this important thing, and it's not really associated with orthodontics, when more severe TMD signs and symptoms are present, simple treatments can alleviate them in most cases. So in most cases, you could help them very easily and in a very conservative way. That means not changing anything on their teeth or occlusion or nothing. Especially because they are sensitive to changes in their occlusion. And in some rare cases you cannot do that, but they have to be included into more complex treatments to resolve their problems. And then you really need orofacial specialists because it includes also heavy medication. So then that
Special
means
institutions.
yeah, that you can do orthodontics without fear of causing TMD. And then also, first, before you start, so you're sure that you can do it and that you won't develop TMD, but you should always perform a screening. That's also what Inform advises. If you want to be up to date, for every patient you will first talk to them and try to see if they had previously some sounds, or if you notice, you should do a quick checkup and to see whether they have some sounds in their joints or mandible that deviates during opening or closing, or have some kind of pain, then you should record this and talk to them about it. And then only after you're sure, you could start the treatment. So what they suggest, that every patient fills out this questionnaire. It's called TMD Pain Screener, which has only a few questions. And then you have scoring. So 0, no pain 0, 1, 2 points. In those cases where you have just two answers to help you, it's 0 or 1. So, and then you add up all your answers. And if you have 3 or more points, then this means that you could have some of the TMD problems. Okay? And then you have to explore further to see what is the cause of the pain. It is not specific for TMD problems. It could be that you have a chipped tooth and then when you chew on it, it causes you pain. You just have to discriminate then later on what is the source of the pain before you can move on to orthodontics. And also, you, by this short questionnaire, you help also patients to become aware that he did have some kind of problem before you started orthodontic treatment, because they're really prone to forget that they had some problems in the past. It's just nowadays that they have it. So you should not initiate your orthodontics before you're sure what's the cause of the pain and that you resolved it, either by putting restoration, sending him to restore that tooth that is painful, or if it has some muscle strains or something, you should resolve it. So, first you make a diagnosis, what is the cause of the problem, if he has this 3 or more, and then you try to help him or send him to someone who could, if you don't want to lose time on this particular patient. First of all, it's counseling. You have to counsel him not to do all this parafunctional activity that he does, or if he had some trauma in the past or something like this. Behavioral therapy to avoid all of those extra movements. Home exercises and physical therapy if it has some problems with muscles, and some massage or warm packs, some thermal packs to relax those muscles if it's a muscular problem. If it's joint problem, then some other kind of exercises before. So only when patient says, I have no pain now, you could start orthodontic treatment. While he's in painful condition, you cannot start to do anything, because it will be obstacle all the time, and you will be the one that's guilty for it, for this kind of pain, and your treatment won't resolve pain. So it's not a thing that could be cured with orthodontics, okay? So if if it is before the start of orthodontic treatment, he has to be out of pain because you can put braces on, okay? And if it develops TMD problems during orthodontic treatment for the first time, then you should inform him and counsel what is the cause of this problem, diagnose, and then try to help him. Is it muscular, is it skeletal, whatever. And then, so differential diagnosis, myofascial pain, conservative treatment. When he's out of pain, you can continue your orthodontics. If it's something within joint, then also conservative if it helps him to take him out of pain, so then you can also proceed further. But you have to suspend all biomechanics while he's in pain, so no class 2 elastics, nothing like just those exercises that you give him during this time. And then continue, only when the patient is out of pain. And it is important to reassure him that it's not orthodontics that caused him these kind of problems, but all these other elements. So this is the list of the possible problems from the side of joint and from the side of muscles. It's also from this consortium Inform. And if they regularly do updates, how much develops the research, they update their guidance, and it's all freely available from their website, and you should follow it, because no one can tell you if you do what they suggest, no one can tell you did something wrong, because you are up to date what can be done and what is the current opinion on this subject. And then treatment options, according to this biopsychosocial model, is just to relieve someone from pain, not to totally change his occlusion. Like, occlusion is not important at all. It should be conservative, reversible, based on scientific evidence, because it was shown that nothing that you do aggressively on patient or change his occlusion is more effective than just massage and exercises at home. So you shouldn't be going into these large restorations, especially because those kind of patients are extra sensitive, and they take it very hard when you change a lot within their mouth. Trust me. So in conclusion, orthodontic treatment is not the cause of TMD, but neither it is not the cure for TMD problems. And it will not prevent the onset of TMD, and it will not increase the risk for developing for anything that you do. It's something that is from this large base within his previous condition and previous experience, and how he processes some information from the outset, and also how a person reacts to some painful stimulus. Yes, thank you. So because it is nowadays, there are three groups of people according to their genetics that to the same painful experience they react differently and report different grade of pain. So that's how we are. We're not all the same. So cannot be treated all the same way. And that's yeah, you can hardly see. And so that's it. I have one case, maybe, but not to be maybe taken on camera or.
Cut.
Huh?